Oh my God. We haven't tortured Dr. Reardon enough. So he's going to give the next two talks. So I imagine you're going to just give them side by side.
Yeah, side by side.
Okay. So TAVR-Device selections on expanding indications and percutaneous alternative access to TAVR. The floor is yours, Mike.
Well, thank you, Michael. So I've got the next two talks, and we're actually about 15 minutes behind, so I'm going to try to get 30 minutes worth of talk done in 15 minutes to get us back on schedule. So let's rock and roll. So device selection, my disclosures, there's two valves that are currently available, the Edwards S3 and the Evolute and Evolute Pro. Core valve has gone through an evolution where we've redesigned the nitinol to have a more consistent radial force across the level of interference, and with the Pro we added an external wrap. If you looked at SWVS, we talked about this early on. The SWVS was mainly a, not to move it by itself, it's mainly a first, okay, who's playing with my slides? It's mainly a first generation trial. It's 84% core valve, only 16% Evolute. We did do a continued access, which moved to 93% Evolute. The only reason I throw that in is this is the first half of SWVS, the second half of SWVS, and continued access, which is 275 patients, contiguous, 79 years of age. You can see what happened is mortality went down to 0, major stroke went to 0.4%, and you can see the line that we're following. So this is an indication of where we're going. Again, we went down, and pacemaker rate's gone down to 16%. The new Evolute Pro, which has a wrap, at 1 year has 90% none to trace paravalvular leak and 10% mild paravalvular leak. Looks a lot like a surgical valve, so we've made a lot of progress along there. The next generation will be called Horizon. It'll be a shorter valve. It'll have larger cells for coronary access. It will expand straight radially, and you'll be able to deploy it 100%, evaluate it. If you like it, let it go. If not, recapture it. So instead of deploying 80%, you'll deploy it 100% and make a decision. SAPIEN 2 has gone through a very great transition from SAPIEN to SAPIEN XT, and particularly to S3, which became the current valve with the skirt on it. It will go to an Ultra, which will be a dry valve that will come pre-mounted. And of course, they have their own self-expanding Centura, which is undergoing trials right now. In the S3 non-randomized arm, they had a mortality of 1.1% and a major stroke rate of 1%. So again, all these valves are getting better and better. The delivery systems are getting smaller. In fact, Centura now has a motorized handle where one operator can stand there and push a button and deploy the valve. So someday I'm going to tell all my fellows, I remember when I actually had to turn a handle, you guys just push a button. You guys have it so easy. The Lotus system, we were part of the Lotus trial. We're finishing up the EDGE registry right now. When that's done, it'll go to the FDA. The EDGE registry is part of the PMA. I expect this valve to be approved either late this year or early next year. It's a nitinol frame that expands, but it has a buckle and a post on the top and the bottom. As you twist a handle, it shortens it, which causes it to widen. It was the first valve with the sealing skirt. This valve you can deploy 100%, decide if you like it, and release it. A lot of data out here. I'm not going to go over all the data, but the 1 and 2 year data showed this thing to have safety equivalent to core valve and effectiveness that actually was better based on less PVL and actually less stroke rate. The next generation is EDGE. The main thing about EDGE is there was too high of a pacemaker rate. The original Lotus valve extruded all the way into the LVOT and then shortened. The big thing with EDGE is it's going to shorten as it extrudes, and it's not going to go out into the LVOT. One problem we've had with this valve is a pretty high pacemaker rate. We think that this will help solve that pacemaker rate because you can see it doesn't extrude into the LVOT. And then the next generation will be called the Mantis, which will maintain most of the same things. It's going to have a smaller delivery system. It's going to be easier to deploy. So there's a lot of iterations coming on. Portico, the Portico trial is done. We were part of the Portico trial. The data has been presented, and I expect a PMA for this valve and approval sometime in the first to second quarter of next year. Again, a lot of data. The Accurate Neal valve has got a CE mark in Europe. It's coming over. This valve Boston just bought. We will have this trial when it comes in. I'll be their surgical PI. It is another self-expanding supraannular valve like the Evolute valve. It deploys actually in 2 phases. It deploys the distal end first, which locks it into place, then the proximal end, which gives it a much more stable deployment. It has a very low pacemaker rate, and it has these really good single-digit gradients because it's supraannular, so this will make it a really great valve for the lower risk. The J valve is another valve that we're going to be doing here. It has these little feet that fit down in the sinuses. This valve will be designed for aortic insufficiency. Right now, we don't have a good valve for aortic insufficiency. and we'll be trialing this valve starting early next year. The Jenna valve is approved in Europe. It's going to start some trials here. They would like us to be part of these trials. We'll just have to wait and see, but it is the only valve that has an approval for AI in its CE mark in Europe, because it also has these little feet that fit down in the sinuses to keep it from embolizing into the ventricle. So the next in line that's going to be approved will be, I think, the Lotus next, followed by the Portico. Then we have to do the Accurate Neo trials. So probably by early 2020, we'll have Accurate Neo. Very rapid progress on the Jenna valve, the Centura valve, and the Venus A valve, which was designed in China. It looks very much like the core valve. The other things that are being worked on very actively right now are tissue-engineered valve. The Zurich valve is a valve that has a living substrate that can be populated with your own cells. Of course, the idea is to build a nitinol frame that has this substrate that can be populated with your own cells. You can put it into your descending aorta and leave it for 3 months and let your own body populate it, recapture it like you recapture an IVC filter, take it out, turn it around, and put it in your aortic valve, because we know what size you're going to need, and we can make one custom built for you. So a bespoke valve, it's going to be hard to beat. Again, that technology is rapidly advancing. This is probably about 10 years away. So the global landscape for TAVR is really large. There's a lot of valves out there right now. These are the current leaders, and these are the ones that are coming along in the future. So TAVR has and continues to evolve very rapidly, user-friendly, lower-profile systems, more precise valve positioning, reduction in paravalvular leak and major complications. Low conduction abnormalities are now our real focus as we move to lower risk. And the evolution becomes more important as we get to younger and younger people. Expanding indications, I'm not going to spend a lot of time on this. We're running bicuspid trials now, even though they're being done. There's asymptomatic severe AS trials that are being done, not for those that are 5 meters or above, but 4 meters asymptomatic. There's moderate AS with heart failure trials, and there's aortic insufficiency valves that are coming out. And then we have to start planning for TAVR and TAVR. We now do TAVR and SAVR, but TAVR and TAVR has a whole new set of complications. Again, because we're way behind, this will all be in your handout. You can look at all this. These are kind of the new things. And of course, 2 low-risk trials, both of them done. Marty Leon should be presenting the Partner 3 at ACC this coming year. I should be presenting the Evolute. Come to ACC. It should be a very exciting ACC. So thank you. I'm just going to press right on. If you can load the next one up for me. Percutaneous alternative access for TAVR. So let's just see where we've gone. Partner 1A was the randomized trial against surgery with the balloon expandable, and 30% of their valves were done transapically, 70% were done transfemorally. You went to core valve high risk, then 70% were done by alternative access, would either be subclavian or direct aortic. They're about split 50-50, but you can see we're now doing more transfemoral, 83. We went to Certavi, transfemoral went to 94. We went to the S3 randomized, they went to 78. And we went to continued access, we went to 95.6% transfemoral. So you can see a clear trend as we move along, and this is to stay away from holes in the chest. And this is what has happened in the TVT registry. Across the country now, 92% of our valves are done transfemorally. The little red spike was transapical. It went up when it was first approved, but you can see it's disappearing. A hole in your heart is not a good thing. If we look at our own, I look back at 3 years of experience for us, and you can see I was very big on doing direct aortics early. We've done almost none in the last 3 years, and 1 transapical. Now, the other access routes we can use transaortic and transapical. They both require a hole in the chest. Holes in your chest are really not good things if you can avoid them. Our most common is transfemoral. Our next most common is axillary or subclavian, and we've also done this transcarotid. There's a retrosternal, suprasternal one that I helped Andy Kaiser develop. It's an interesting approach, but it's losing its appeal since we have so many other alternative access. And then we have transcaval. Transaxillary, we make an incision when we do it open in the deltopectoral groove. You split the fibers of the pec major. You can either divide or remove the pec minor. And then the artery is right there. The thing you have to be very careful of is the brachial plexus is right there. This is an incision for those of us who do a lot of arch work and do it all the time. It takes us about 5 minutes to do. It's very easy to close. It can be done under local anesthesia if you want to do these as a conscious sedation. Again, we look for an area right by 3. There's a little branch you can see here if you take an arteriogram. But if you're going to do this percutaneously, you need to do this with a Doppler. You should really be doing everything with a Doppler. And the main thing when you do this with a Doppler is you find the artery and you look for the bright spots. The bright spots are the cords of the plexus. Do not poke the bright spots. That's a bad thing to do. You can get a wire in there. When you do this, you get a wire in there and you shoot a picture to make sure you're in the artery and you're where you want to be, while you still have your mini catheter in there. If you fail with your mini catheter, you can actually just pull it out. You can hold pressure if you're lateral enough. Once you get too medial, it disappears under the clavicle. Now, one of the things we've seen with axillary is it's already been shown, Tom Gleason published this paper, that the outcomes for axillary equivalent to transfemoral. Transapical and direct aortic are not equivalent to transfemoral. And in fact, the other safety outcomes when you look across there for axillary versus transfemoral, exactly the same. KCCQ, quality of life, exactly the same. Goes up at exactly the same rate. Transcaval, we go in with a venous, we cross from the cava to the aorta with an electrified wire, and we put a sheath all the way over, 18, 20, it doesn't really matter. When I first heard about this as a surgeon, I thought this is crazy. There's a giant hole in the cava, a giant hole in the aorta, that can't be a good thing. But even if you pulled everything out, what happens is the aorta goes right into the cava, it creates a big AV fistula. You don't bleed to death because the cava becomes your auto transfusion. And if you close this with a plug at the end, it'll close off. It's actually an interesting way to go. We've yet to find one that we couldn't do either carotid, transaxillary, or transfemoral. And that was kind of my criteria to go to transcaval, and we've yet to find one of those. A lot of people like this, and some people have even moved to this to be their first way of doing this. Transcarotid, you make a little tiny incision in the neck, like you're doing a tiny carotid endarterectomy. You go down next to the sternocleidomastoid. The only muscle you have to cut is the sternocleidomastoid. Everything else you just pull out of the way. You put your 6 French sheath in, you cross, you do your hemodynamics, you put your stiff wire in, and then you put your sheath in and do your valve. The valve is indwelling for only about 10 or 12 minutes. First of all, you can occlude most people's carotids without causing a stroke. So, and second of all, as long as you're in and out pretty quick, you can do this. If you do this with TCD, you can monitor the flow in the middle cerebral or on that side. You will know if you're in trouble instantaneously. You don't have to wait until they don't wake up. So if you're going to do this, do it with TCD. You get immediate feedback. Again, it's relatively easy to do, except for the fact that our sheaths are not designed for this. So here's one we're really doing as an inline. So it makes it smaller. This is with an Evolute Pro valve. And then when you close, it's very easy to close. These people are awake at the end of the procedure. You can do this under local. It's just really uncomfortable for the patients. But as Neal talked about, there's no difference between general anesthesia and local, as long as you have a good anesthesiologist, and wake them up at the end. Don't ever leave them intubated. The suprasternal, I spent a lot of time developing this with Andy Kaiser. We have what looks like a fancy mediastinoscope, and you can expose the ascending aorta. We usually use the base of the innominate artery. The Mike Borger at Columbia was doing a lot of these before we went back to Germany. The problem, again, is we have so many other alternatives, this has lost a lot of its appeal. So really the conclusions is that I can't spell conclusion, I guess, but non-femoral access is becoming increasingly rare. That's why I'm a heart surgeon and not a cardiologist like Michael. Non-femoral access is becoming increasingly rare. Right now, our personal femoral access in the last year is 98%, and that's basically taking all comers. Alternative access does not violate the chest wall, may be roughly equivalent when we get enough data. And we talk about alternative access, which gives you the idea that alternative is somehow worse or bad. I think we need to start talking about transthoracic access and non-transthoracic access and change our terminology. Thank you very much.